All right, let's do something a little different today. We're going to put you right in the hot seat. We're simulating a high-stakes surgical viva. You know, that make-or-break oral exam every surgeon has to pass. I'll be playing both parts, the tough examiner and the candidate who's on the spot. We're going to break down a life-and-death emergency, from the second that pager goes off to the very last stitch. Ready? Let's get started.
Okay, so the clock starts now. Here's the situation. 70-year-old guy on blood thinners, and he's bleeding. A lot. He's already in shock. This isn't just some textbook question. This is a real-life catastrophe waiting to happen, and every single second matters. As the candidate, my first words have to be perfect. They have to be immediate, structured, and most importantly, safe.
Thank you. My absolute first priority is resuscitation. This patient is circling the drain, so I am hitting the big red button, activating a full trauma-style response. That means I'm starting with the ABC protocol, but I'm also screaming for help. I need a senior surgeon, I need anesthesia, and I need the ICU team. At the same time, I'm getting the blood bank on the line, telling them to get ready for a massive transfusion. We are in a race against time here.
So, A is for airway. Is he conscious? Is he talking? If not, a simple chin lift could literally save his life. B is for breathing. I'm checking his oxygen levels and getting him on high-flow O2 right now. But C, circulation, that's where the real battle is. I need my team to get 2 massive IV lines into his arms and start pushing in warmed fluids. We're just trying to buy ourselves some time until the blood gets here. Think of it like trying to refill a tank while it has a huge hole in it.
And as we're getting those lines in, I'm drawing a whole rainbow of blood tubes. The CBC will give us a hemoglobin level, but here's a key pearl. It might look falsely normal at first because he's losing whole blood, plasma, and red cells together. The coagulation profile is absolutely critical. I have to know exactly how to reverse his anticoagulants. We're ordering at least 4 to 6 units of blood on emergency release. And that ABG with lactate, that's my real-time number telling me just how bad the shock is. The higher at lactate, the sicker my patient is. Stabilize first, then we find the leak.
Okay, good. The patient is being stabilized, for now. But the examiner wants to know if I can think beyond the immediate chaos. Am I just a technician, or am I a thinking surgeon? I need to list the likely causes for this bleed, and I need to do it in a logical way, starting with the most common bad guys.
For a 70-year-old with a huge, painless bleed, my #1 suspect, no question, is diverticular disease. It's the absolute classic presentation. Next up would be angiodysplasia. You can think of these as tiny, fragile blood vessels that can just pop, and they're most often on the right side of the colon. Now, cancer usually causes a slower, more chronic bleed, but sometimes it can present just like this. And of course, I'm keeping less common things in mind, like ischemia or a complication from a recent colonoscopy. And yeah, hemorrhoids are common, but they almost never ever cause a bleed this big.
So, we've got the patient stabilized for the moment, and we have a list of suspects. Now it's time for the detective work. We have to find the crime scene. We're pretty sure it's in the colon, but the colon is a big place. We have to pinpoint the source of this bleeding if we want any chance of stopping it without doing a massive operation. First things first, I'm doing a rectal exam and taking a quick look with a proctoscope to make sure this isn't just a really bad hemorrhoid. But here's a huge pitfall. Sometimes, a massive bleed from a stomach ulcer can travel so fast through the intestines that the blood still looks bright red when it comes out. So, I'm putting down a nasogastric tube. If I get back bile but no blood, I can be pretty confident the problem is truly in the lower GI tract. This is a critical step to make sure we don't end up operating on the wrong part of the body.
Now, if we can get him stable and keep him stable, we can use some pretty cool technology to find the bleed. Think of it like this. The tagged red blood cell scan is like a smoke detector. It's incredibly sensitive and will tell you, hey, there's a fire somewhere in the house, but it won't tell you which room. Angiography, on the other hand, is like a thermal imaging camera. It needs a bigger fire to see anything, but when it does, it shows you exactly where the flames are. And even better, it lets you spray some water on it through embolization.
And right here, this is the most critical decision point in this entire case. If the patient is still unstable after everything we've done, if we are just pouring blood and fluid into him to keep a blood pressure, then we are out of time. Forget the fancy scans. The next stop is the operating room, period. Any delay at this point is a gamble with his life.
So the decision's been made. We're going to the OR. But before we even think about picking up a scalpel, we have to have a very serious, very direct conversation.
Look, getting informed consent in a crisis like this is tough, but it is my absolute duty. I will explain to the patient and his family that this surgery is to save his life.
I'll cover the general risks that come with any massive operation on a sick, elderly patient: blood clots, heart attacks, pneumonia. These are the baseline risks. And then, I have to get to the really scary stuff that's specific to this operation. The biggest risk is that we can't stop the bleeding. There's a risk that the new connection we make in his bowel could leak, and that's a total disaster. There's a risk of injuring other organs nearby. And I will be crystal clear about the very high chance that he will wake up with a stoma, a bag, that could be temporary or it could even be permanent. They have to know that going in.
All right, it's time to scrub in. So for this scenario, let's say we've successfully localized the bleeding to the right side of his colon. The definitive operation to fix this is called a right hemicolectomy.
So what is a right hemicolectomy? Well, it means we're removing a pretty big piece of the bowel, the very end of the small intestine, the appendix, and the entire right side of the colon. As you can see here, this move takes out the whole blood supply to that area, which should get rid of whatever is bleeding. Then, of course, we have to reconnect the plumbing, joining the small bowel back to the remaining colon.
So here's my game plan in the OR. I'm making a big incision right down the middle to get the best possible view. First, a quick tour of the whole abdomen, just to confirm we're in the right place. Then, the main event. Mobilizing the right colon, freeing it from its attachments, carefully tying off its blood vessels, removing that whole segment, and finally, putting everything back together.
This slide shows one of the first, and honestly, one of the most elegant steps of the whole operation. We're cutting along something called the white line of Tolt. It's the attachment of the colon to the sidewall of the abdomen. This gets us into this beautiful, bloodless plane that lets us lift the entire colon up and away from all the important things hiding behind it.
And this right here, this is where a surgeon really earns their paycheck. As we lift that colon up, we unmask some incredibly important real estate. The right ureter, that's the tube that carries urine from the kidney, is lying right there. So is the duodenum, the first part of the small intestine. Injuring either of those is a career-changing, life-altering complication. The mantra is simple: see it, protect it, and preserve it.
Now here's another key exam point. Even though we're in here for a bleed, we have to do this operation as if we're treating cancer. And what that means is we have to take out all the lymph nodes that drain that part of the colon. The magic number is 12. If we don't get at least 12 lymph nodes for the pathologist, and this turns out to be an unexpected cancer, we haven't done the job right.
The surgery is over, the bleeding is stopped, and the patient is on their way to the ICU. But we're not done. The exam isn't finished. Now comes the post-operative period, which is honestly just as critical as the surgery itself.
All right, let's boil this whole thing down to the key exam pearls. Number 1, resuscitate first, always. ABC. Number 2, remember, most of these diverticular bleeds, about 75%, will stop on their own, but you have to be ready for the 25% that don't. 3, an unstable patient belongs in the operating room, not radiology. 4, know your anatomy. Angiodysplasia loves the right colon. And 5, in the OR, be paranoid. Protect that ureter and duodenum at all costs.
Excellent. So we've navigated the storm. But now for the final and maybe the most important question of all. What is the one complication we fear most in the first few days after this surgery? And what are the earliest, most subtle signs that it's happening? I'll leave you to think about that one, because recognizing and reacting to post-op complications, well, that's what truly separates a good surgeon from a great one. Thanks for joining us.